Good evening, everyone. Thanks for joining me. Thanks to the GHAPP MASLD Community Network and also Madrigal for inviting me to share my knowledge with you. I hope you have a good learning experience while we talk about non-invasive testing for hepatic steatosis and the options that we now have available for our patients. As she so politely introduced me, my name is Marcella Pomeranz. I've been a nurse practitioner for 8 years in inpatient and outpatient GI. I'm lead nurse practitioner for our large group in Las Vegas, so I have a desire and a passion for teaching, and I'm excited to be with you here tonight. So this is a QR code that you could have used to register for the meeting.
Marcella, I do not see your slides.
Oh, yeah? Let's see if I can share again.
There you go. Can
Okay.
you go to full screen mode, please?
Yes. Is that good?
That is perfect.
Okay, sorry about that. Okay, so we're going to dive right in with a clinical case study. So I'll introduce our patient Albert, who's 65. He comes to our hepatology clinic for elevated liver enzymes. He's had some workup before he's coming to us, which is kind of nice to have on our initial visit. So he's already had an abdominal ultrasound, which was remarkable for increased echogenicity with consistent with steatosis. We have some labs. Luckily, he's already had a chronic liver disease workup, so we've ruled out autoimmune and other genetic causes of his steatosis. His triglycerides were 89, HDL 41, A1C 7.2%, and notably his ALT has been known to be elevated for the last 3 years or so, about 1 to 2 times upper limit of normal. As far as his alcohol history, he denies any use since his 20s. He does have some comorbid conditions that will increase his risk: type 2 diabetes, hypertension, and hyperlipidemia. On exam, he has some abdominal adiposity, but he doesn't have any stigmata of advanced liver disease. Of note, he is Hispanic and his BMI is 29. So based on this, we've already ruled out other chronic causes or met ALD. There's no significant alcohol component here. So we can confidently diagnose Albert with metabolic dysfunction associated steatotic liver disease, or MASLD. So luckily in 2025, we have a slew of options, as you can tell from this slide, to assess his liver. We don't need to rely on liver biopsy like we used to decades ago. We have lots of imaging, serologic markers that we can use to help identify his risk. So for biomarkers of liver fat, even when we get an ultrasound, usually our radiologists are commenting, is there mild, moderate, severe steatosis? We have MRI, we have our CAP, which is our controlled attenuation parameter, which will give us a measurement of steatosis based on elastography, and we'll talk about that in more detail. We have our MRI PDFF, which is a really great tool that we can use to accurately see how much liver fat is going on. And then we, more importantly, have imaging biomarkers for liver stiffness, because that's what we care about, right? So we have our shear wave elastography, our vibration-controlled transient elastography, MR enterography, elastography. So you'll see in the yellow on this page is going to be our more frequent used NITs, or non-invasive tests, and just more that we have access to as well. So on the right side of the slide, you'll see that we also have some clinical tools that we can use with basic information to try to assess risk. FIB4 is used almost exclusively on almost every patient that walks into our clinic, even our screening colonoscopies, because lots of patients have comorbid conditions and we want to be assessing them early for any steatosis and help slow progression. It's so important. So with FIB4, we can use almost always the routine labs that we've received to help identify risk. Then we have the NAFLD fibrosis score, which uses the same components as FIB4, but we also have, our albumin and BMI in there. And then our APRI is also just some, our ALT to platelet ratio index that we can use to help assess patients at risk. Luckily, we also have serologic testing with biomarkers that can assess fibrosis as well. So the PRO-C3 ELF, I would say, is the most commonly used, which is our enhanced liver fibrosis serologic test, but we also have FibroSpect, which sometimes we use more with hepatitis C and MASH, or Fibrometer, which is really nice because it includes other demographic information as well as biomarkers and other algorithms to assess fibrosis. And sometimes it's not clear. We might have one NIT that shows some indeterminate, and then the elastography doesn't give us quite a confident diagnosis here. So we can use combined rules where we do FIB4 with AST or MR elastography with FIB4 or AST. And sometimes we need that to help us determine who really needs a liver biopsy to figure out how much fibrosis is going on. So we'll dive into our most commonly used NITs. So the FIB4 calculator is a really easy tool to use on almost everyone. Age and AST, ALT are components as well as platelets. So if we put this into our calculator and we get a score of less than 1.3, we have a high negative predictive value that this patient has been excluded from having advanced fibrosis. It's also really good to show if the patient has or is at risk for MASLD. Conversely, if the score is greater than 2.67, now we're starting to worry about some advanced fibrosis. And if it's greater than 3.48, now we're really worried about cirrhosis. So it's a really quick and easy tool to help assess and identify those patients. Once we get these, we can use a secondary non-invasive test to get a better measurement, but this will definitely help capture early. One of the limitations of this exam is age is a factor, right? So if a patient is less than 35, we might be, not getting an accurate measurement, or if they're over 65, we're going to change our thresholds a little bit. So we're actually going to want it to be less than 2 for this population to exclude any advanced fibrosis, and that will allow us to identify patients and account for age. So the ELF test, which is our enhanced liver fibrosis score, measures 3 direct biomarkers of fibrosis. And if you're curious what those are, we have P3NP, hyaluronic acid, not the same one we use for skincare, maybe, and then our TIMP1. So they get 3 scores that will help to identify patients with significant fibrosis. It has good diagnostic accuracy. The cutoff point is about 9.8, and this exam has a 60% specificity and 85% sensitivity. So it's a really nice tool. Patients just do a blood test rather than having to go for additional imaging. But one limitation is cost, because sometimes insurances don't pay for it. Then we have our non-invasive assessment of liver fibrosis and liver stiffness measurement. So stiffness is the ability of an object to resist deformation in response to an applied force. And we use shear waves to get these measurements. They'll actually travel faster through a stiff liver. So we want slower shear waves to travel through. And then liver stiffness increases with fibrosis stage, right? So the more stiff, the more fibrotic. Here are some examples of pictures of different elastographies. So first we have a transient elastography, an MR elastography, which shows you that nice mapping of the waves going through the different parts of the liver. Then we have shear wave, 2 additional types of shear wave on the bottom. And we'll talk about elastography, MR, and vibration controlled a little bit more as well. So here's our vibration control transient elastography. That's what the machine looks like. This is a non-invasive quantification of 2 physical biomarkers of the liver. It takes about 10 minutes to do, so it's really quick, non-invasive. So we get the CAP score, which is that controlled attenuation parameter, which is going to tell us how much steatosis is going on. And then we'll also get a measurement of liver stiffness through that vibration controlled elastography, which correlates to the extent of fibrosis. So it's nice to have a steatosis level and a fibrosis, and it's really used over time to show progression of illness. So it's nice to be able to do this over time to show them how their liver has gotten worse or hopefully gotten better with lifestyle and other interventions that we have. So both biomarkers can be used to assess the disease severity in different etiologies. So whether it's alcohol, which can inflate, especially if there's significant transaminitis, but MASH or hepatitis C, in the spectrum of causes of liver disease, it's still a great tool to assess for fibrosis. There are some considerations. One is there's usually about 10 measurements that are taken during this exam, and we want to make sure that all 10 were taken. And as providers, we don't always get that information, right? We're relying on the operator. We just get the final report. But just so you know, there should be 10 measurements done during the FibroScan, and then the IQR over M should be less than 30. And that's basically what is the variability between those 10 measurements. If it's less than 30% variability, then it's a more reliable test. What was the image quality? Did they get good pictures? What was the success rate to obtain the 10 measurements? I'm not sure about you, but I've never seen a level of difficulty in doing the exam, right? So we assume that it was done well, but not always are they able to get good pictures. And I have had patients tell me that the operator told me that it was really hard to get those pictures and recommended that I do this in a year, but they don't really put that on the report, right? So it's important to be using reliable people to do this exam. Is the operator experienced? Another thing not on this slide is how overweight is the patient. They do have better probes based on BMI, but we have to make sure that the facility we're using has access to those. So some other considerations for the vibration control transient elastography is there are some other limiting factors. For example, if a patient has significant transaminitis, if their ALT, AST is over 100, that's going to influence the results of the exam and may overinflate the level of actual fibrosis. Ideally, we want patients to be avoiding alcohol for several weeks before we do this exam, but in a perfect world, we can't always get that, but we just need to take that into consideration. Or maybe we have a patient that with ongoing alcohol, significant alcohol use, we get a baseline FibroScan, and then we say, hey, if we do this again in 2 or 3 months, if you've been avoiding alcohol, then we'll get a better picture of the actual level of fibrosis that's going on. Another thing to consider is cholestasis. So if the bilirubin is over 2 to 3, or the alk phos is over 1.5 times the upper limit of normal, that can also overinflate the results of this exam. Patient factors, we'd like them to be fasting for 3 to 4 hours before the study. How much alcohol are they using? Is that influencing? How obese are they? How high is their BMI? Is there any ascites that might affect the waves that are passing through? Or liver masses? Clearly, liver masses like HCC are going to be much more stiff, even in a fibrotic liver. So if a patient has an ultrasound and there's a liver mass, then maybe this type of elastography is not the best test, because if they do those 10 measurements and most of them are over that liver mass, then it's going to hyperinflate their level of fibrosis. So the MR elastography uses shear wave technology and an acoustic driver on the patient to produce this multicolor elastogram. So that's that pretty picture on the top right. Some considerations for the MR is BMI. Sometimes very large BMIs we know may have a hard time getting into some of these machines, may limit access for our very obese patients. Iron overload will influence the shear waves going through and change that elastography pretty dramatically. Some patients have implants or other devices that may not be MRI compatible, so we need to make sure that they're safe for this study. A lot of people have a hard time with MRI because they're claustrophobic. So we need to see if they're willing to do that. Maybe a FibroScan might be a better option for them. If they have any significant hepatic congestion, maybe heart failure, that's also going to inflate these readings. And then insurance issues, because we know MRIs are expensive. So this is a nice table that was created to kind of compare our non-invasive biomarkers of advanced fibrosis. So we have our indirect serum fibrosis biomarkers, including our FIB4. We know that that takes into account our age, transaminases, and our platelets. So the rule out cut point is less than 1.3. Rule in cut point is greater than 2.67. Unless they're over 65, then there are some adjustments. Limitations of this exam is there's a low positive predictive value, about 40%, and then it's less accurate when it's performed on those age extremes like we talked about. 30% of the time, they may get an indeterminate in between those two, the rule out and the rule in cutoff points, and then we'll need to rely on a secondary test to get more information. But at least it's really good for it has a negative predictive value. So that means if that score is less than 1.3, the chance of them having any significant fibrosis is very low, minimal. So you are reassured that nothing significant is going on. And we can use routine clinical data. Minimal data is required to get this score. Also, patients most likely have already done these tests before they've come to see us, so we don't have to send them for an additional exam to get more information. Then we move on to that direct serum fibrosis biomarker, the ELF score. The rule out cut point is less than 7.7. Rule in cut point for our advanced fibrosis is greater than 9.8. Some limitations are we do have to send out patients for an additional test. And like I mentioned before, cost is variable. So we just need to make sure that they're aware there may be a fee. Maybe they want to check with their insurance or lab before they do the serology so that they make sure they're not slapped with an unexpected high bill. Strengths are it has a very high negative predictive value. And then we have our imaging fibrosis biomarkers, which really have helped us rely much less on liver biopsies. So that vibration-controlled transient elastography will give us a measurement in kilopascals. Rule out cut point is less than 8. Rule in cut point is greater than 12. There are multiple potential confounders, right? Especially operator experience. There are transaminases, all those things we talked about before, BMI, the quality of the measurements and the variability between the measurements. And then it requires, some expertise on how to perform this exam. Some strengths are it's point of care, so it's pretty easy to do, and there's a high negative predictive value. MR elastography also gives us a score in kilopascals. Important to note that they are not the same as the vibration-controlled transient elastography kilopascals. So if you do transient elastography, you cannot go then to MRI to compare results. It's like apples to oranges. So you always use the same imaging fibrosis biomarker to stage progression over time. So for the MR elastography, our rule out cut point is less than 2.5, and our rule in cut point is greater than 3.6. Our limitations here are high cost because MRIs can cost a lot of money and it's not widely available. For example, even in a big city like Las Vegas, I don't have access to MR elastography, but luckily we have lots of FibroScans around. And then some strengths are they're highly accurate and there's few confounders. So let's go back to Albert, who we've diagnosed with MASLD, and what can we do to assess his liver disease right now? So we know his labs, his ALT is 43, AST 38, and platelets are 170. So we do a FIB4, we already have his labs, we calculate that quick in clinic, and it's 2.22. So that's in that window of the indeterminate risk, right? Can't really reliably rule out or rule in advanced fibrosis based on this serological calculation. So what can we do next? We have the MR elastography or we have a FibroScan. In this case, we chose the FibroScan and he came out with a 6.7 kilopascal, which put him at low risk, fortunately. So patients with MASLD with low risk, we're going to really encourage lifestyle modification, optimizing his diabetes, hypertension, hyperlipidemia, getting his metabolic disease under tight control. And then we'll repeat his non-invasive test in about 2 to 3 years to see if he's had any significant change in his fibrosis. So this is a nice QR code if you guys want to scan for disease state education. You can visit the GHAPP MASLD MASH Community Network for additional webcasts and information. And then this is a QR code if you want to leave us some feedback, as we always appreciate your thoughts and how we can improve.